Welcome to the fourth episode of Let's Talk About Access. What a pleasure to have today with me Nick Inston, transplant and vascular access surgeon and president-elect of Vascular Access Society. Nick, welcome.
Hi, Alex. Good to see you. And thanks for inviting me along. I've enjoyed the ones so far with Dr. Jennings and Kate Steiner and Brian. They've been great.
Absolutely, absolutely. And as we are both a bit of provocateurs, and I think we like very much to challenge people with our questions. I thought, what a better opportunity to have a discussion about what is fake news in vascular access. You know, fake news with President Trump is an expression is being used very often, and I think we have also fake news in medicine, surgery, and of course vascular access. So, what would you identify as fake news in vascular access? Something that is troubling you often in UK?
So I think there's a vast amount of fake news, and if we're saying fake news, it's, I guess, manipulation of the data is probably a better term. But you know, there's so many things and decisions we make in vascular access that are not actually what the data says. It's the data fits us. You know, I think a good example. You know, you look at fistula first. All the intentions for fistula first are there, and at the time, you know, patients were online, patients were on grafts, and the graft use in the USA was huge. But actually, trying to make fistula in every single patient was detrimental. We found that in the States. In the UK, I found that very quickly, that what I was ending up doing was, you know, we started to call it grandma torture. You know, we were taking little old ladies who were doing perfectly well, you know, on a central venous catheter and happy with it, and then doing things to them and causing them problems. And I remember one particular lady who, you know, she was independent. We did a fistula, she got steel, and actually she then needed nursing care. She needed a family to get involved, and we didn't do her any favors at all by creating a fistula. And that, you know, I know that's N equals 1, but there's a lot of patients like that. And I just saw the US RDS report from the 25 data, and actually the rate of catheters in the US has remained static for the last 10 years. And actually the rate of fistulas has gone down. So, you know, pushing harder and harder and harder to do fistulas doesn't necessarily mean that it's the right thing to do. And I think we discussed it once before, and there's a concept that you may be aware of. It's called the Cobra effect. And the Cobra effect comes from, again, English people, but the English viceroy in India, and the streets were overrun with cobras and snakes. So he put a bounty out that if people brought him a dead cobra, then actually give them money. And this worked for a very short amount of time, and people were turning up with all these snakes from the streets. But once they started to clear the snakes, they ran out of income. So they went and bred snakes in farms and brought them into the city and actually increased the number of snakes in the city. And then he stopped paying the bounty, and the city was overrun with snakes. So we've got to be really careful about those. I guess the right term is untoward consequences of some of the actions and some of the rules that we put in place.
Very, very good points, Nick. I totally agree with you. I had the same problem with some patients, and I had the same conclusion. You know, the patient that was just doing great with a catheter, or sometimes pre-dialysis patients that you do a fistula and then you have to do balloon, reballoon, superficialization, occlusion, new fistula, and the patient for 2 or 3 or 4 years, no dialysis, or has a functional catheter that we didn't have to change it at all. So definitely we need to identify patients better. And I think the problem is more, if you wish, the dogmatic acceptance of some rules.
Absolutely.
But just following the same rule, like do a distal fistula in the non-dominant arm in all patients, without taking in consideration the anatomy, the stage of the patient, the status, overall health, the training of the surgeon, who is going to do the fistula, because that's the other thing. You know, not everybody is going to do a AAA open surgery fenestrated, but for a fistula, it's like an open season. Everyone can just go do the fistula and do it again, etc. And often these patients, you know, sometimes they're illiterate, sometimes they are so used to being in and out of the hospital, they're not even asking the questions. So definitely there's lots of work to be done there. But do you think this is because the data are not good, or because we tend to try to issue rules and guidelines too much without having data?
I think it's both. You know, the data is pretty good for a lot of these things, but we pick the headlines. You know, people will always say, you know, a fistula is the best form of vascular access, and of course we don't disagree with that. You know, I'm fully in favor of that, but actually a working fistula is the best form of vascular access. A fistula that's not working very well, or a fistula that fails, is not the best form of vascular access by a long way. And what we can't do is just pick out the results from patients who have their first fistula and do very well on it and apply it to everyone. It's similar to the concept of central venous catheters kill people because the survival with a central venous catheter is worse. And of course, a large number of patients who are on central venous catheters have had fistulas in the past, have had, you know, failed fistulas, have gone through a whole process, and it's selection bias that often is the case that people die. You know, I'm not advocating that we should use more central venous catheters, but we need to understand the data properly. One of the reasons I think this stuff gets pushed when it gets to policy is that actually protocols are good, but protocols are not there as solid rules, are they? And you need someone who's got experience to interpret them. I mean, another area of this that really starts to make my blood boil is, you know, not enough people start on fistulas, so we should create fistulas earlier. And, you know, we had a big drive in the UK to push fistulas, you know, people being referred with GFRs of 18 and then 20 and then 21. And what we were doing was actually giving people fistulas. They weren't needing them. The futility rate was high. The waiting list for fistulas was going up, so the people who did need them weren't getting them. And then people, as you say, were having interventions before they ever needed their fistula. We actually created a problem. I think it was the last VAS meeting, and a patient stood up, and it's probably the most sort of telling thing I've heard at a vascular access conference. And he said, the day I got given a fistula, I got given a new disease.
Yeah.
And actually, that is what we're creating. We're not creating some benign single, it's not an x-ray. You know, this is something that needs work, needs assessment, needs looking at, needs good cannulation, needs a whole process of care. And we're creating it. And that, I can see why a lot of patients don't like fistulas.
I think you're right. And of course, in an effort to avoid giving the impression that we are against fistulas, I think I will say what was my experience and what I'm trying to do now. And of course, both of us, we are on the side of the spectrum of surgeons with lots of experience. Yeah, and it's easier for us to judge now. So after myself having failures with fistulas or doing fistulas for many times it didn't work, and patients with catheters that finally I said, why did I even bother to do this fistula? Basically, what I'm doing now, when I see a patient, first of all, I'm asking if the catheter that they have already had problems or needed to be changed.
Yeah.
If the patient says that he has a catheter for 2 or 3 years and they have absolutely no problem and the catheter is working well, never had infections, never had to change it, you know, I'm already thinking whether I'm going to create a fistula. And if I'm going to create a fistula, I really want to have good vessels. I'm not going to go with the guidelines, you know, okay, I have a 2 millimeter artery and 2.5 millimeter vein, so we have the guidelines, so we need to create a fistula. I want to see vessels that, based on my also gut feeling, if you wish, I have a beautiful vein, beautiful artery that I'm almost like 99% that I'm going to do one surgery and it's going to work. And the patient is going to have his catheter off. And also the patient also asking for it for some reason, you know. For example, I cannot take a shower, I have some discomfort, some pain, etc. And the same thing applies for grafts. I'm also putting more often grafts in comparison than before, because what I say is it's better to have a good graft than a bad fistula. So if I have a good vein that I can superficialize, do whatever, and I will do a fistula. But if it's a big arm, small vein, I know it's going to need, 2, 3, 4 operations, then I'm not reluctant to put a graft. So, and I think this is kind of bringing us to probably the spirit of the guidelines. Yeah, the recent guidelines, let's say that we need to adjust with patients, but do we have enough training of people and trained and experienced people around the world to be able to do this thing reliably for so many patients?
You're absolutely right. And, you know, I take your point from earlier. Neither of us are advocating that fistulas are intrinsically bad. You know, we still, I think, should be looking at every patient for the appropriate access, and the appropriate access for the majority of those patients will be a fistula. You know, it will allow them better life, you know, activities of daily living, showering. It's a discrete form of access on the whole, unless it causes problems. But I'm not saying they're easy to make, but your point is very valid. A straightforward first-time fistula. There will be many people around the world who can make those, who are not necessarily high-volume, complex access surgeons who don't have an overview of the full pathway for renal patients. And I think in the past, some of this has been a problem, that surgeons act as a sort of hired gun. You know, they get referred a fistula, they may do 5 a year. They have no consequence of what happens to those fistulas afterwards. I mean, when I started my career, we had a vascular surgeon who did that, and he did just snuff box fistulas. And he would stand up and lecture and say he had 100% success with snuff box fistulas. And of course, all the problems came to us because the patients didn't go back to that practice. So I think it's really inherent on people doing this work to at least know what the outcomes are. And the outcomes aren't just someone leaves the hospital with, you know, a buzzing fistula or not. The outcomes are down the line as how many of those fistulas were functional, how many were usable. Your comment about grafts, you know, a lot of grafts are put in, but unless you're mindful about how nurses have to cannulate grafts, then you can put a graft in, it can be perfectly good, but it's not functional. And functional access is what we're talking about here, isn't it? Yeah,
correct. Nick, how about what I realized more recently, the last, should I say, 5-10 years, probably less than 10, is that the industry seems to be a bit more interested in the AV universe. So we have DCBs, covered stents, endo-AVF, but this means there is also probably some introduced bias in the studies and the data. Not necessarily for any bad reasons, but definitely possibly some bias and some conflicts of interest. Is there any fake news there in DCBs or covered stents?
So I think across the board, you know, we've been very lucky over our careers, over the last however many years that we've known each other, to be involved with some really interesting innovations in the whole field, not just vascular access, but, you know, in the medical field. And of course, it comes across as fake news, but if you start to analyze a device, the outcome measures are not necessarily real world measures to start with. And we've seen this with, you know, endo-AVF, percutaneous fistulas, etc. The first studies were there to prove that you can create an anastomosis, that it's safe, and that it's usable. Now, you've got to have reasonable endpoints, and you can't use necessarily the standard Kadoki endpoints for those studies. But those endpoints then get pushed on. And for example, if you're talking about functional cannulation, you can use an intent to treat analysis, but if actually you're using a new device and it didn't work for a number of cases, you don't get an idea of when you created that fissure, is it cannulatable or not? So I think some of that can come across as fake news. I think that area is flattening out a little bit and people are getting an idea of what the real outcomes are there. And we've seen definitions change. You know, we've discussed it in conferences, either of us on the platform, as what the right definition for primary patency is. And actually, does it matter? Because what matters is whether or not that fistula can be used at the end of it. So I think there's that side of it. The drug-eluting balloon side of things is interesting because we've got conflicting studies. Some studies showing one thing from industry and other studies that are independent showing a different aspect. And then some of the areas I've been involved in, the sirolimus study on fistulas, which basically showed no difference between the control group and the other group. But what it actually showed is that in the study, the control arm actually overperformed where we predicted it to. So studies are not necessarily real world, because they often have, you know, what we call experts or enthusiasts doing the surgery. You know, you don't use it as a training case. Perhaps the follow-up is much more intensive. Your interventions are keener. So I don't know how we get that data. So it's not sometimes coming across as fake, unless we just do registries, real-world registries. I don't know if you've got any views on that. That the impact of a study, and the PAVE study showed this, the control arm way overperformed what we expected.
Well, for sure. I mean, if you do a study that is sponsored by the industry, and everybody inside the study starts with a positive bias and willingness and desire to make it work and demonstrate that it works, well, finally, chances are that it's going to work. And of course, the other thing is that, you know, sometimes you get a paper that says improvement of patency, I don't know, statistically significant of 20%. Yeah?
Yeah.
Which on paper sounds impressive, sounds dramatic, but finally, is it going to make an impact in the real world?
Sure is clinically relevant, yeah.
Yeah. So do you think what we actually call level 1 evidence, like all the randomized trials, etc., is a bit overvalued finally, or perhaps sometimes misleading?
I think it is misleading in our field, because the studies for devices are never going to be high. You know, if you're looking at that sort of difference in a drug trial, cardiovascular drugs, where you're recruiting 30,000 people and population studies and want to remove all those biases of lifestyle and all the variation, fine. But to do that in a study that's powered for maybe 80 patients per arm or 100 patients per arm in vascular access, there's so little room for actually making that study appropriately powered. If you miss the p-value, it's a huge impact on the device, because, you know, the funding disappears, the device disappears off the market. Yet that's solely because in that group of patients, which is small, perhaps the primary output, the primary endpoint was not the right endpoint to be looking at. So I think we've got to be really careful with those studies, and I'm not sure our community demand that sort of evidence. I think the vascular access community is quite close, and I think there's lots of discussions and lots of areas to discuss these things. So I think actually an element of common sense does come through, and an element of pragmatic review of real-world data comes through. But of course, if the regulators need randomized controlled trials, we're kind of stuck with that.
So do you think we're kind of, as a subspecialty, doomed to be just at the level of expert opinion, having you, me, and 5, 6 other guys around the world going to the conferences and saying to other people how they should do things?
I honestly think there is. You look at the Kadoki guidelines. You know, you go through things that are what we think are way established and evidence-based, and nearly everything in there is low level of evidence, cannot recommend, expert opinion, use things. Again, central venous catheters, there's 15, 20 of these things on the market. There's no evidence to support one over the other.
And Nick, do you see any... Of course, there's so much evolution in the medical field that is transforming medicine. Do you see any potential for future evolution in medicine, transplantation, that might even make vascular access surgery obsolete?
Yeah, that's a really good question. I think one of the most interesting things at the moment, and I've just been following on LinkedIn, is that the implantable dialysis device, the Aphrodite device, has just been given FDA accelerated clearance for development. Now, I think that would make a massive difference. You know, we know patients who are out having regular dialysis, as in home hemodialysis, look better, feel better, have better lifestyles, have better quality of life. Now, how we deliver dialysis at the moment, 3 times a week, 4 hours at a time, is not based on best quality clinical practice. It's based on the logistics of how we deliver dialysis in a cost-effective fashion. You know,
yes.
If it was me, and I'm sure if it was you and we had to have dialysis, we'd like to do it at home with our own control, managing our own lifestyle, probably with a glass of wine, sat on our favorite armchair. So actually we need to look at things like that. So I think the way we deliver dialysis, if we can bring dialysis more into patients' control and more ambulant, I think that would be a massive step forward. In the transplant field, obviously all drives, live donor transplantation is a fantastic thing. You know, there's not many diseases we have a cure that, 4 hours of surgery fixes an entire multi-system disease. Live donor transplantation is obviously the best. Cadaveric transplantation is a good substitute, and many programs are reliant on that. The advances in things like xenotransplantation, transplanting animal organs, there's been some push in the US. One thing that my mentor said when I first started in this field is there's not many things that will proven untrue in the world, but xenotransplantation will be one of those. And I'm yet to see anything that convinces me it's going to take over. But, I'll be happy to be a skeptic that's proven wrong, because if we can get a ready source of organs for patients, that would be a great thing. I worry about immunosuppression loads. I worry about infections, transmitted infections, those sort of things. And I don't think we've got over that at the moment. But that Nephrodite, the implantable Holly dialysis device, looks really exciting if that can make progress.
Yeah. Nick, you are director for many years of the vascular access session for Charing Cross. And of
Sure.
course, I'm doing the same thing for PVI in Paris. And of course, these conferences need sponsors and need partnership with the industry. How do we manage to balance things and avoid using our platforms for the diffusion of fake news? That's a difficult role.
True, yes, that's a very good one. And, a lot of these things that we work on, we're enthusiasts for. Those biases you said earlier for a company, a lot of our enthusiasm is not for financial gain, but for making things work. And the innovation in this field is exciting. We're in it for that reason, and we want to make things work. And often we can stand at the front and sound like we're badged and we've got the T-shirt and the trademark tattooed on our arm for some of these things. Because if you're setting from the start and you're developing a device and you're involved in that, and then the clinical trials, you may be in this stuff for 10 years and you get badged with that. And, both of us have been in that situation where, we're very integrally involved with trying to make something work in the place. And it does seem that you are in some way partisan to that device. Yeah. But it's the only way to do it. I think your colleagues in France with the endo-AVF trial, I've actually stepped beyond that and actually pushed that. And independent trials, I think, do have a role, but they're an awful lot of work and they cost money, and you end up pushing yourself real hard to get to that point, when actually, being an invited speaker at a conference is quite nice. What I would say is things like Charing Cross, and I'm sure PVI, is that we don't choose people for that reason. These are independent. These are CME, CPD applied for conferences, and there has to be demonstration that these people are not being paid for opinions. These people are not doing bias. They're presenting, they're experts who are presenting the data that is there in an unbiased way. So I think that criticism will be leveled at some of the more commercial conferences, but I also think, these things cost money. Industry sponsors these things. In the whole, I think you'll find the same. PVI, it's the same sponsors, and it's actually quite a broad range of sponsors who are at these conferences, and a lot of data gets presented from different areas. So I don't think these are advertorial sessions, and if they are sponsored sessions, it's always very clear, because you know, we'd be in big trouble organizing conferences if we are putting people up there who are paid speakers, really.
Yeah. And
I don't know. Have you got similar views, or?
Do you know what? It's a difficult task because, first of all, you have your own biases. Second, you try to maintain balances because you want the conference to be successful, but also you need your partners from the industry to be happy. But in the end, you need to have a moral compass and try to produce something that is, as much as you can, honest, and people that will dedicate their time to come and watch this podcast or whatever, get something out of it. Not just try to force feed them some information. And I think in the end, if you try to do that, it pays back because people are not stupid. Yeah. I mean, you can try and go out and say, this is the gold standard and this is perfect and this is the best thing since sliced bread. And perhaps you can be successful one time in doing that, but you're not going to be successful forever. Yes.
Yeah, totally agree with that. You know, the audience will call someone out who's making unsubstantiated claims without any data. You know, if you stand up there and say this is great, but you've got nothing to support it, you'll do that once, but you won't last very long.
Yeah. Nick, I want to thank you very much. I hope we'll be able to do this again and analyze some other topics, perhaps more technical or other. I wish you a great rest of the week, and I'll see you soon in one of the future conferences.
Sure. Thanks very much. Keep up with these, Alex. They're really good. I'm enjoying them all.